My name is Pam Liston. I'm the host for this afternoon. I am a commissioner with the JCMH, and I am experienced in magistration and judicial duties in the state of Texas, going on about 12 years now. I'm currently a senior attorney with the law firm of Messer Fort and McDonald, and I'm a city attorney for many municipalities in this North Texas area. I have practiced in both the municipal law and criminal law contexts for over 25 years, and I've specialized in safeguarding public trust in the judiciary through professional fairness, organizational accuracy, judicial education, and faithful application of the law. So our first speaker this afternoon will be Dr. Andy Keller. Dr. Andy Keller is the president, Chief Executive Officer, and Linda Perryman Evans Presidential Chair of the Meadows Mental Health Policy Institute, a Texas-based nonprofit that provides nonpartisan policy and program research, development, and advice to local, state, and national leaders. Meadows has a single goal: improving mental health care delivery in Texas and across the country. Dr. Keller is a licensed psychologist with more than 20 years of experience in behavioral health policy, financing, and best practices. Welcome, Dr. Keller.
I like how you emphasize the more on the 20, because you always have to keep track on your bio. When do you have to upgrade it to 25? When do you have to upgrade it to 30? And I don't think it's going to be a while before I have to do 25. So hey, everybody, thanks for letting me be here today. It's great. It's exciting. I love Judge McClure's overview because it's cool that we have 180 counties represented. I mean, that's kind of amazing. But I want to kind of start out by just do a little audience participation here. There's going to be question times later. So be thinking of things you want to ask me or tell me I got wrong, anything like that, because that'll be the funnest part of what we do today. But one of my theories about the Judicial Commission is it's sort of the Reese's peanut butter cup theory. I remember those commercials, you get your chocolate in my peanut butter and your peanut butter in my chocolate kind of thing. To me, that's what the Judicial Commission on Mental Health is. Like, I don't believe there's actually mental health judicial people. I think there's judicial people and there's mental health people. So I wanted to kind of take a little survey, like how many of y'all consider yourselves more judicial people? Okay, pretty good. You guys don't like to raise your hands very high, but I think I got a sense. How many of y'all consider yourselves more mental health people? Looks like we have more mental health people, or at least y'all raise your hands higher. I don't know. Maybe you've been through more therapy, so you really do it. So how many people want to defy my earlier point and consider themselves mental health and judicial people? There's got to be a couple. Yeah, I knew there'd be a few. You're wrong, but just to be clear. So I'm really excited about that because it is exciting to see that we do have such a cross representation of that, because we really do need to come together on these things, because the reality is the reason these things don't work is because each of our systems are designed for them not to work. So you all, as understanding how our systems are designed, are the perfect people to have working on this, because we need to kind of deconstruct some stuff together and build some new stuff together. And I'm going to talk about that. So I do want to talk a little bit about us. So that was a really nice introduction. I would like, we should have an arrangement too to do that more, because that was nice. It was one of the, because I hate having my bio read. It's something that you don't really like doing, but you did it fast, which I liked. But the Institute has been around now. This is actually our 10th year. We just started our 10th year 4 days ago, because our first board meeting was on the 29th of October in 2013. And we're primarily driven by philanthropy. So that gives us independence to be able to work on different issues. And one of the things that one of our board members, Justice Harriet O'Neill, made a priority and went to talk to Chief Justice Hecht about at the time was we need a Judicial Commission on Mental Health. And whenever Harriet O'Neill says something's going to happen, you know it's going to happen. So we can all thank Justice O'Neill for being here today, because it was really her passion to working with Christy, with a bunch of other people, to make this happen. So that's the kind of thing we do. We try to help get cool structures set up to transform mental health systems, because we don't think they're working all that well today. And I'm going to talk more about that. But we work in sort of two spheres. We work on state policy, whether it's working with the judiciary or working with the legislature or the executive branch. We also work, though most of our work is in communities, trying to see what works, what doesn't work, how do we make things better, and then what are the barriers in terms of financing policy that we can then work on in Austin and with our partners. And increasingly we're doing more national policy that really, I think, became as a result of COVID, because mental health traditionally is funded much more at the state and local level, but beginning with COVID, the federal government has actually increased its investment in mental health threefold, which is not always saying that much because they hadn't increased it for like 15 years. So they kind of caught up to where they were going to go. But also with the bill that was passed this summer, often called the gun bill, the Bipartisan Safer Communities Act, that was a $12 billion increase in the nation's mental health funding, which, when you do the math, 1/10 of 20 billion is only about 1.2 billion. So for us, that's not even, a month of what our mental health system costs in Texas. But it's some really nice additional dollars to be able to help out. So there's some cool things going on at the federal level. So that's what we do. So I thought it would be helpful if we could start talking about what is different about mental health and substance use disorders from other health conditions. And they're really not different in the sense that they're not illnesses. They are illnesses. But I want to talk about how we treat them differently. And I think you're going to have access to these slides. So if you want to take pictures of them, it's totally cool, but we're going to make sure you get them too, just FYI. So this kind of begins to get the difference. So one thing up at the top is how many people died in 2020 from overdoses, some of which were really poisonings. A lot of the deaths that are overdoses are actually people who poison themselves accidentally, thinking they're taking one thing and finding out it has fentanyl in it. So that's a big reason of what drove those 30%. Those are 30% higher than the year before, which is bad, in case that's not clear. It's actually horrible. There's no other health condition, other than maybe COVID in the first round, that we are doing as bad a job at as the addictive illnesses. And we're not doing much better on mental health either. We lost 46,000 people in America in 2020, and we lost more last year. And the only year where suicide went down was right at the beginning of the pandemic and during the pandemic. And one of my theories is that so many people with mental illnesses died during COVID, it has actually reduced the available number of people to die. So these are some of the only health conditions where year over year, as opposed to cancer and heart disease, we're losing more people and doing a worse job. So I am on the mental health side of this equation. I'm a psychologist, so this is my fault. This is my people's fault because we haven't done some of the things we've done with medicine. So on the other kind of medicine, the rest of the body medicine, the below the neck medicine in this chart, the stuff that's in the green, we send people to the doctor and they discover that you're ill before you do. If my heart disease, they came and told me, hey, you're on a track and you'd have a heart attack because of your cholesterol. They told me that when I was 30 years old. They've been haranguing me about it since. They don't tell me to wait for chest pains and then to call the police when I have chest pains. That is, by the way, what my grandpa did. When my grandpa found out he had heart disease, he had chest pains. My grandma drove him to the hospital. He died. They resuscitated him. He was in the hospital for 2 weeks, came home, and that's when they put him on a low cholesterol diet. That's how they used to do things back during the 70s. That's how we do things today, more often than not, in the mental health system. We wait until people are in the justice system. We wait until people are in the emergency room. And the whole point is we wait until people figure out that they're sick. And that's a really bad idea. And we've had to design the justice system to compensate for that, because a big thing that people do when they have mental illness as opposed to heart attacks, when you have a heart attack, you might scare the person you're with, but you're not going to scare anybody else because you pass out. When you have a mental illness, you're in crisis, you're talking about things, you're taking your clothes off, you're walking in traffic, you scare other people. Not because you're necessarily going to hurt somebody. We way overestimate how harmful mental illness is to other people. And I'm going to talk about that actually in quite some depth in a bit. But it scares other people, and so we've had a public safety response to that historically. And that's why we have to do so much disentangling, because we treat these conditions as public safety conditions as opposed to health conditions. So I'm not going to go on and on about that, but I do want to talk a little bit about why it's complicated. And this is one of the biggest reasons, is that 75% of mental illnesses begin before you're an adult. And some of you have seen these pictures before, because several years ago I used them, but actually this is the first place I used these pictures. And it's been really moving to people, and I've gotten so many positive comments on it, not because I look particularly good in these pictures, but because it helps illustrate, I think, how mental illnesses begin. So this is baby Andy at age, I think, I don't know, getting baptized. So baby Andy and his parents are there, and I had my anxiety disorder first discovered by my mom and me when I was 4. Because apparently when I was 4, I said, Mom, I'm so anxious. And she was really impressed by this and decided to write it down in my baby book, I think because I used the word anxious. But my mom would call me the WUF kid. Because, in retrospect, I don't remember her calling me that at the time, but she would say it in the back, looking back, it's like, Mom, what if the house burns down? What if Dad doesn't come home? What if, we have a hurricane? Well, we don't have hurricanes in central Washington, Andy. We do have volcanoes, but we don't have hurricanes. A volcano? What if a volcano goes off, Mommy? So, this was, the childhood for my mom. And my mom actually was extremely resourceful. If you look on her bookshelf, there's all these books about like, how to raise the difficult child. I think one was Breaking the Strong-Willed Child, which I don't think that one worked out so well, but like there was a lot of these 70s era books trying to get my mom to be helpful. And actually my mom did a really good job. I mean, look, I'm going to prom, 18-year-old Andy looking sharp. That's how we dressed back then. But this is the age, I didn't want so much to show you my prom picture. I wanted to show you what 18-year-old Andy looked like, because while most anxiety disorders, which is what I have, begin by age 5. 50% of anxiety disorders have manifested by age 5. That's not the case for the more severe disorders like psychosis, schizophrenia, bipolar disorder. Schizophrenia and psychosis, the onset is between 15 and 25. But almost everybody who eventually has a psychosis also had an anxiety disorder when they were young, because your brain processes different information differently. You could be super smart, you can be different in other ways, but anxiety is actually commonly co-occurring in people with psychosis. So if I had been tracked using the current standards, which the medical profession recommends, actually they just recommended this year, that at age 8 we screen all children for anxiety disorders. If we screened all children for anxiety disorders starting at age 8, we would be able to help parents like my mom got help, but we'd also be tracking Andy if Andy was someone who at age 18 was going to develop a psychosis. We would already have a plan. We catch it early before Andy knew he had a psychosis, before his family knew he had a psychosis, and we'd be able to help him better. And that's really the shift we need to make, because this is 49-year-old Andy, a bit younger than I am now, back when they would say over 15 years of experience. That's what they, 49-year-old Andy is relevant here because this is the age I would have died on average if I had a serious mental illness in Texas, because that's when people die. And we don't die of suicide mostly. We die of heart disease, infectious diseases, COVID. There was nothing that predicted death from COVID more, and I'm going to talk about this a little bit later in a little bit more detail, than depression and psychosis. Only age correlated with death more. And this travesty about that is the CDC didn't know that until a bunch of advocates in mid-2021 came together, we were one of them, and petitioned them to look at the scientific data that showed that mental illnesses were actually killing more people as a comorbid condition of COVID than asthma and all the other things that got you early access to vaccines. So these are the reasons why we need to shift the system and why so many people end up in your system if you're on the judiciary side. So let me also talk about this. If you look at depression, for example, to apply it, we have about 21 million adults in Texas with depression, in the United States with depression. We actually have probably more than that today because these are pre-COVID stats, but I'm just going to go with these because that's enough. We only detect clinically half of those people every year because we don't want to. We don't ask the questions that we have. We could detect them. We have very valid tools for detecting depression, but we don't like to use them because we don't have enough clinicians. We worry that if we find somebody and we don't have a clinician, then that creates a moral dilemma. I'm not sure it's any better than the moral dilemma of ignoring a disease, but it is something that we worry about. But here's the thing that's even worse, is only half of those people that we find every year get to treatment. And that's because it's so hard to find a therapist. And also because we refer people. If we actually treated folks in primary care, which is where we treat a lot of illnesses, we would be able to get a whole heck of a lot more of them. But then this is the thing that makes me the most upset. Of those 24% of people that get to a clinician, only about a third get to something that works. Because we still send people to play therapy. We still give people, send people to like residential treatment centers for depression, which is a stupid place to send someone if they have depression. You may send them for other reasons. They may also have depression, but you don't do that for just depression. So we send them to places where they don't get better, and that's really the biggest travesty. So of the ones who get to treatment that is actually the kind of treatment you should get, 2/3 of those people get better. This is what our current treatments are. They get people better 2/3 of the time, and it's almost that good for psychosis. 50% of people with psychosis are going to get better quickly, and then another 20% are going to get better over a multi-year period. The problem is we don't detect people and get them assertive treatment fast enough. We send them to your jail, we send them to the emergency room. So I want you to keep all this in mind, because when you are looking at someone in your court or someone in your mental health center, you're thinking, wow, they're in the jail right now. I wish we had a hospital. That would be good to have a hospital. And we're going to talk a little bit about what some of the issues are around not having enough hospitals. But it actually would have been better if their primary care doctor talked to them 20 years before. So when you're doing reforms in your community, you need to think about that bigger picture, not just what's going on in your court, not just what's going on your patrol if you're a law enforcement officer, not what's going on necessarily in your clinic. You got to think about how do we get ahead of these things faster, because that's actually the only way we're ever going to reduce the number of people coming into your justice system. Talked already about COVID and the impacts, but the thing is, we have a whole lot more depressed people and anxious people in the United States today than we did. It's still 4 times over baseline. It actually ticked up. I don't know if it's the election or the recession or what, but it was going down in the summer. It was only about 3 times as high as the pre-COVID baseline, but it was higher. And one cool thing about COVID is CDC actually started monitoring depression and anxiety rates. We weren't doing that before COVID. Now we do it, and we have some idea about what's happening in the country, and we knew what the baseline was, but we haven't been able to track things over time. Now we are. It's interesting to me, you never hear on the news that this might be one of the things contributing to why so many people are out of the workforce. Like, people don't like to argue about this. I guess there's not a lot of political points to score talking about these kind of things, but I think it's actually one of the biggest reasons. And the number of youth going to emergency rooms right now with suicidal attempts, being lost to suicide is higher than it's ever been. So it's not just that our numbers are higher, they're starting to affect people younger, they're starting to affect people who are more diverse. So the lesson, though, I think we want to take from COVID, and it's the one I've been trying to talk about earlier, is we didn't get ahead of COVID by kind of finding people right before they died and trying to help them get better. What we did was we tried to find them before they knew they were sick, and we got them assertive treatments, and then ultimately now we're vaccinating people. So that's really early detection, early treatment, stay out of the hospital, stay out of the emergency room. That's where we need to go. So it's something that it's important for us to keep in mind, because that's not typically where we encounter people in work. In our work, I mean, at home we might encounter people in that way, but at work we're encountering people typically on one of their worst days. And we're going to talk a little bit more about that, but I wanted you to have this background. And feel free to bring some of this up when we come back. So this is what things should look like. We should be screening for depression, anxiety, and then ultimately psychosis and other more severe disorders in primary care, finding people early, getting people to routine care, and really never involving law enforcement unless they do something that requires them to have law enforcement. People with cancer sometimes need to have law enforcement because they do bad things, but we don't do it as part of their cancer treatment. So that's kind of the vision that we want you to keep in mind. A really important question, though, I want to talk about today is one that a lot of us have been struggling with since late May, and some of us have been struggling with this longer because we remember earlier episodes like the terrorist attack on the El Paso Walmart, the school shooting at Santa Fe in 2018, but on that terrible day in Uvalde back in May, this question came to the forefront again. And it's important one, I think, for us to have a common understanding on, because the things you heard, the sound bites you heard right after that of mental illness has nothing to do with violence, or mental illness, violence is a mental illness, are both wrong. And I want to talk a little bit about what the data shares on that, because it's really important, because you guys are at the tip of the spear for these types of interventions, and we want to make sure we understand that. So what is a mental illness, first of all? A mental illness is something that's treatable. It's not something that's weird about your brain. We all got weird stuff about our brains. That is not a mental illness. A mental illness is something that's treatable. And I'm going to talk about violence here in a sec, but the things that are mental illnesses are depression, post-traumatic stress disorder, bipolar disorder, schizophrenia. Doesn't mean that we successfully treat them all the time, but they're things we know how to treat. Violence is not something we know how to treat. Violence is a human condition. And mental illnesses on their own do not cause violence. And I want you to hear this really closely. Violence is not a mental illness. And it's extremely important that any discussion you have about mental illness and violence begin with that statement being said unambiguously and clearly, because for centuries, people have equated mental illness with violence. They basically said people with mental illness are violent. We're going to get into those numbers here in a sec. But the thing that's important is that violence is a human condition. We could be violent for noble ends, protecting our family. We can be violent for evil ends, trying to murder someone in a white supremacist rage. So centuries of prejudice have to be fought anytime we talk about mental illness and violence, but we can't let it stop us from talking about it. And I'll tell you, during the discussion during the summer when Senator Cornyn and Senator Murphy were working on the Bipartisan Safer Communities Act, a lot of mental health advocates sidelined themselves in that discussion and were not helpful because they were so emphatic about needing to tell the world that mental illness was not violence. And that's super important, But there are things we can do in the mental health treatment system to prevent violence and to help people not end up in bad ends. So I'm going to talk about that. One of the things when we look at all violence is there's really no statistical association between mental illness and violence. Like in my mental illness, anxiety disorders were way less likely to not just hurt people, but to tell people that they're bothering us because we're too anxious to say it. Mental illnesses like depression make you more likely to hurt yourself but not other people. But some mental illnesses do result in more violence. So severe mental illness has a slightly higher risk of violence when you parse out poverty and substance use and other things that are drivers of violence regardless of who you are. Untreated psychoses, though, are the thing that are most associated with violence, and it actually creates a 15 times higher risk of murder, committing murder, if you have an untreated psychosis. Now, a couple things to keep in mind on that. That's actually not that high of a risk. The risk of any of us committing murder is extremely low, so being 15 times something that's very low is still a very low number. But statistically, this is the set of illnesses that we need to focus on the most if we're going to focus on violence. But they're also something that should have hope because see the key term there? Untreated. When we treat somebody, when we provide treatment, it takes away that entire excess risk. So the issue with untreated mental illness is not that the mentally ill person is violent. The issue is that we have not provided adequate treatment to help somebody maintain their safety. And keep in mind, it's still a very small subset. This is a hard thing for a lot of advocates to deal with because a lot of advocates are so focused on the stigma piece that they lose sight of the fact that we actually do have some data we need to act on, and it's unfortunately our job to point this out. So hopefully the data get better over time, but this is the best data we have. There's also been a lot of new research since 2021 on what causes violence in schools. And when we look at that subset of mass violence, which is different than violence in general, because we don't have mass violence happen enough to have deep understandings of it, we have to look at case studies, we have to look at aggregate numbers. The U.S. Secret Service in 2021 put out a report on averted school shootings, and this is the profile that they came up with. I'm going to talk about here in a sec. And actually, before I do, I also want to mention another study that came out through the Violence Project. Both of them looked at very large data sets. The U.S. Secret Service one looked at all 67 averted school plots over the last decade that they were aware of. And then the Violence Project looked at every mass shooter since 1966, which I was born in 1966, and look how old I am. So that's a lot of data that they used. So here's what they found. The common characteristics of people who do school attacks are always teenage males. I mean, there have been a few young adult males and actually some of the ones that were carried out, but it's exclusively males who do not have their brains fully developed. They all had exposure to early childhood trauma and school discipline issues. They generally had hopelessness and despair and isolation, had bullying and abuse that they suffered, had an identifiable crisis point, generally with suicidal ideation, and then had this sort of self-hate that turns against a particular group. And the way to think about it, that the researchers talk about, is it's a basically homicidal suicide. You don't like yourself, you want to end your life, but you want to do it in a way that acts out the grievances you have. And you know, y'all, a lot of these things, actually every one of these things at some point is a treatable mental health condition. If you look at the shooter in Uvalde, when he went to school 2 years ago in the fall with cuts on his face, talking about dead cats in bags, these are hallmark signs of an agitated, potentially violent depression that we know how to treat. And it makes me sick that we didn't recognize that. And when I say we, I mean we. I don't mean the people in Uvalde. I don't mean the people at the school. We didn't give them the tools to do that. I mean we as a state. Even though we stood up a TCHAT system that was designed to do exactly this, we didn't get TCHAT to Uvalde. Even if we had, we might not have done the training in the school to help people know when they should identify these signs. So I'm here to tell you that if we had those services in place, there's a very good chance something different would have happened in Uvalde. And so this subset of youth is something we can do about. But the issue is these youth don't have psychosis. A few do. A few of these school shooters do. But the by far larger set are these sort of self-hate turned outward, basically a depression and trauma-based type thing, and almost always with a chaotic home and family situation. And so the problem is, you can't go looking for these youth and saying, hey, those are your school shooters, because there's 10,000 youth like that going through that by our estimate. Now, I don't know if it's exactly 10,000. I know it's not 5,000, and I know it's not 15,000. And so 10,000 is the number we use as an estimate based on the best data we can find. The vast majority of those people almost all of them are going to have really bad lives if we don't help them. Some are going to hurt themselves. A larger number are going to hurt someone else. Almost none of them are going to do a school shooting. I mean, that's something that's going to happen. It's hard to predict. But our theory is it's a haystack theory. You don't look for the needle, you treat the haystack. If we helped all 10,000 of these youth, which why wouldn't we want to do that? Their lives are going to be better, and we're going to be able to avert some violence. And I think really it's violence in general that we need to think about, not school shootings, because look what happened last year. I mean, in 2020 rather. Violence, for the first time in a long time, actually claimed more lives of Texas youth than suicide did when we look at homicide and intentional killing or accidental killing of a youth by another person. Violence is the thing that's is the second largest killer of Texas youth after accidents. So when we talk about violence as a public health need, this is what we talk about, but we need to talk about it in a very nuanced and careful and thoughtful way. And we are. The Texas Child Mental Health Care Consortium was stood up in 2019 on the heels of both Hurricane Harvey and the Santa Fe school shooting. And the express purpose of the Texas Child Health Access through Telemedicine component, the TCHAT component, was to give as many schools in Texas as possible a way to rapidly identify a youth of concern and get them to an expert at one of our 12 state-funded medical schools who could help the school determine whether or not they're at risk. So if little Andy's drawing pictures of dead bodies and guns and the teacher's worried, TCHAT was set up so that the teacher could talk to them. And if it's an emergency, you could get a consult immediately, but typically this isn't an emergency. It's something that you want to get parents involved in and you need to get parents involved in. So it sort of sets up a whole process around that, but the TCHAT program is to basically hold the hands of the school and the youth. And so some of you may know Sarah Wakefield, my favorite psychiatrist in Texas. I like a lot of other ones, but Sarah's my favorite. Sarah is the chair of the Texas Tech Department of Psychiatry. And I called Sarah, actually, I think it was the day after, in the afternoon after Uvalde. I said, Sarah, I'm talking to some people, and we don't have data on this yet, but would it be fair for me to say to people that we have averted some instances like the Uvalde shooting using TCHAT? And she said, no, Andy, you can't say that. I said, well, why can't I say that? And she said, because it's not some, it's a lot. She's like, I see youth all the time that meet this profile. I don't know if they're actually going to do a school shooting. Some of them are threatening that, but we have caught a lot of youth, and we've been able to help them. We've been able to get them because these are not hard to treat conditions. It's super hard to stop a youth 2 weeks before when they buy the gun and they're buying the ammo. That's not very treatable at that point. It's 2 years before when they have cuts on their face, when they're threatening suicide, when other things are happening. So that's really what CPAN is about and trying to find. There's other things the consortium does, which we can talk about, but we have TCHAT right now. I'm sorry, TCHAT, not CPAN. CPAN's in primary care. I get my acronyms mixed up sometimes. So TCHAT we have actually in 50% of our schools right now. We only had it in 40% of our schools in the summer. We've kind of ratcheted it up and increased it by another 25%. But the Texas legislature, as part of what the governor, lieutenant governor, and speaker signed off on in the summer, basically fully funded TCHAT for every school that wants it. Not every school is going to need it. Some schools have other arrangements with their local mental health authorities, with their own clinics, with FQHCs that work well for them in terms of being able to provide immediate access to urgent mental health needs. But for any school that doesn't, the state now has fully funded TCHAT. So by the end of this school year, we should have all 1,200 school districts, all of them that want it, and all 5,000 or 7,000 school buildings with access to TCHAT. So that's something we're doing as a state. But the other thing is, you can't just do telehealth for somebody like the Uvalde shooter. The Uvalde shooter needs something, the only thing actually that research shows would work effectively for someone like his situation, where you've got a family who really is overstretched and doesn't have the resources. I mean, he had a grandma there. He had other families involved. He had a mom who had a substance use disorder who was outside the house. But those are adults that the therapy called multisystemic therapy, that's what they do. They come in, they find the adults in a child's life, and they help those adults get supported by other adults in the church, in the community, in the school, and they basically create a responsible set of adults around that child to help them have the guidance and nurture and support they need. And multisystemic therapy has been shown over a 20-year period, 20-year outcome, to reduce the incidence of violent occurrences among youth with these conditions compared to treatment as usual and compared to baseline. So it is super effective. We have 7 teams currently delivering MST in the state. We actually got funding in the summer to ramp up 7 more, which was the most that we thought and others thought that we could ramp up in the fall of this year. We need 140 of these teams. So we're at about 10% of capacity. I expect there to be 20 more, hopefully in the next session, that we can ramp up. But this is something we're going to have to do over time, because until we have access to this universally, we're not going to be able to help young people like the Uvalde shooter avoid the kinds of outcomes that we don't want them to have. As I mentioned, there's also a risk with psychosis. And one thing we've been working on for quite a few years in Texas are early psychosis programs. Texas has, as far as I'm aware, the largest infrastructure in our local mental health authorities of any state of being able to provide early treatment for psychosis. So it's basically assertive treatment in the first 18 months of when symptoms emerge. Because typically what we've done before these programs is we waited years until y'all found them in your justice system, or mom and dad got upset, or the young person became homeless. And so people with psychosis now have access to 37 CSC teams, coordinated special care. It is the gold standard. It works fantastically. And we're going to be adding more of those teams. We added 2 of them over the summer that are youth focused, and we need to lean a little bit more into that youth space, which is a little harder, but it's one that we're hopefully going to be able to develop more capacity on, and will be developing more capacity. And then the last thing that research shows that we need are youth-specific mobile outreach teams. We have a wonderful mobile crisis outreach system in the state of Texas that's really designed around diverting people from unnecessary hospitalization and getting people care in crises. What the research shows is you can't wait that long in families. For families, you need to have more of an urgent treatment response, and cities and communities that have implemented these urgent treatment teams, where you can go out early in a crisis, get resources, and then follow that family for 60 to 90 days to help them get the care they need, have shown amazing outcomes for youth that haven't yet been connected to care. Because even if we have all those other teams in the TCHAP program, we're not going to find everybody. Or we're going to have people who fall out of care. Things happen, and there's going to be urgent situations, because that's how life is. So being able to have these teams deployed is one of our largest things that we're hoping will happen next legislative session. So that's the array that's wrapping up right now, and it's something that it's important for you all to be aware of, and it's important to think about how your community can both access these resources, but also make sure that they respond to the specific needs of your community. So I want to shift gears a little bit away from youth and talk about probably what most of you spend most of your time dealing with in your justice system, which is mental health and substance use related emergencies. So when someone calls 911, when they come to the attention of law enforcement, when they show up in your court or your clinic, and they're having one of the worst days of their life. What's going on there? Well, the way we do this currently, and I'm talking right now at the point of crisis, isn't working very well, because we still as a nation, not just in Texas, but as a nation, rely overly on law enforcement. This is sort of the expectation, is that law enforcement is going to be the people who go out and respond to people, and that's not good for anybody. A disproportionate number of fatal police shootings involve people with mental illness. We got millions of people coming into the jail every year. I already showed you the suicide statistics. But it's also bad for law enforcement, because we're spending a lot of time dealing with health conditions when we should be dealing with public safety conditions. And even if the people get to the ER, that's not really the best thing either, because they're boarding there, they're not getting to the places they need to go to. So what can we do differently? Well, one thing that's a new resource, is anybody here, who here has heard of 988? That's pretty good. I bet you're the mental health people in the group. One thing that we've not done very well as a country, it's not specific to Texas, is letting the justice system know that we now have a new 3-digit number called 988 that people can call when they have a mental health emergency. What 988 does is it takes the suicide crisis line, the National Suicide Prevention Lifeline that had been there for years, and rather than having to remember the 10 digits that you previously needed to do, and if you were a veteran, you had to hit an extra number when you called, now you can just call 988. You can get to that line. A lot of those calls are answered by mental health centers in Texas that are very knowledgeable about the community that you're in. Some roll over to the national line, but all of them are designed to help people get to access quickly. And it's cool. It's a good thing. But it's more an opportunity than it is a solution. Part of why it's just an opportunity is at least half of you had never heard of it before, and it's been operating for 4 months. So that tells me that we probably need to do a better job with our law enforcement and judicial partners. I was at the IACP conference a couple weeks ago, the International Association of Chiefs of Police, and actually the numbers of police chiefs in that room who were aware was even lower. And it was actually a breakout session on 988. So people actually came not knowing what it was. So, and that's what we see when we look statistically, is we really just haven't gotten the word out yet. And there's reasons for that. One of the biggest reasons is that while we got resources for the phone, we didn't get resources for anything else. So we're still dealing with the crisis systems that we had pre-988, which actually in Texas are pretty good compared to some of the other parts of the country. We've actually been systematically improving our crisis response systems, building out crisis centers, building out capacity in our rural areas with our local mental health authorities really since 2007. Doesn't mean we have everything we need, but compared to other states, we have a really sound base of expertise in our local mental health authorities that we can build on. But what we haven't really built out is that sort of three-pillar system that we need. We need to have a place to call, and that place to call, by the way, needs to not just be freestanding, it needs to be integrated with 911. Because sometimes there's violence, sometimes there's questions about safety that need to be integrated. We also need more mobile crisis teams. We have some good ones, but we don't fund that adequately. We could absolutely fund that more. Also keep in mind too that the response time of law enforcement is targeted at 4 minutes ideally, but never more than 8. The expectation for a mobile crisis team is like an hour, which is actually, that's the national standard. We're not behind, but like, think about that. How are we gonna get there quickly enough if we're coming in an hour and police can show up in 4 to 8 minutes? And then the last one is we need more beds for people to go to, and you all know that, and we'll talk more about that in a little bit. So this is in the sequential intercept model before you get to the sequential intercept model. And one reason why we've really kind of shifted away from the Institute a lot of focusing on sequential intercept mapping, I mean, we think it's good. You all should do it in your justice systems, but we don't spend a lot of our time doing it because we don't want folks in your justice systems. Once folks get in your justice systems, their outcomes and their likelihood of being able to get better go way down. And it doesn't mean they shouldn't be there. Sometimes they need to be there. But if we can keep people out entirely, then you don't have to worry about whether they have competence to represent themselves. You don't have to worry about whether they're in your jail safe because they're not in your justice system. They're somewhere else being kept safe. So that's what we try to focus on there. And you know, we really need to build not just capacity, but also values like no wrong door, like being able to figure out how to say yes no matter what the question is, because something needs to happen if someone is in crisis. They may not need to go to a hospital, they may not need to go to a crisis bed, but they need something. And so we have to figure out systems to do that, and we also have to figure out the right balance of law enforcement and mental health. And so 988 reform is good, but we would argue that 911 also requires reform. And until we move into our emergency response system, we're really limiting the number of people we can respond. And one thing that's kind of cool is in Texas, we've come up with this idea of multidisciplinary response teams. And it is a Texas model for coordinating response that originated in Dallas and now has gone to quite a few other communities. And the neat thing about it is it's integrated with law enforcement and paramedics and social workers, and they go as a team. And so the law enforcement officer is there in case there's a need for them, but they kind of hang out in the background, and it's really led by the paramedic and the mental health clinician. But we don't have to do a triage, figure out is this a dangerous person or not. And you know, when you get into dangerousness assessments, a lot of times you have implicit bias there. You've got other things that get in the way of people making accurate decisions. So if we just use the system we have, then we're disproportionately going to be sending 911 to people who are perceived to be dangerous, even though they may not be, as opposed to having a system that treats people more equally. So that's really why we've pushed it. We've compared it to some of these other kind of leading things, like some of you may have heard of the Denver STAR program or the Be Heard program in New York. There's some other programs in the country that have civilian-only response. Probably the most famous one is Cahoots. I think they had a good marketing team because it's just fun to say Cahoots. If we had named our team Cahoots, we probably would be as well known in Texas as the Oregon team is. The problem is those teams don't go out in a lot of circumstances. They don't go out a lot of times if there's substance use, certainly they don't go out if there's weapons, and they certainly don't go out if there's a report of violence. Whereas these multidisciplinary response teams that we now have in Texas and quite a few communities do go out because they have the public safety component there. They have the tactical response capacity. A lot of the social workers, actually the social workers in the original model were the ones that wanted Kevlar the most because they knew that things could go bad, and they're like, we're willing to go into more cases if we know we have a bulletproof car and the ability to be safe if the tactical situation becomes dangerous. And by the way, we tend to prefer emergency room nurses because emergency room nurses are the toughest, coolest people on the planet. And they know that if you come to their hospital, they know what they can do. And a lot of times the hospital is not going to be able to do a better job than what they can do in the community. So I want to just jump down. Dallas Fire and Rescue, Dallas Police, Parkland were the partners in the initial one. But you know, if you look at the outcomes they had, only about 2% of people were new arrests. Another 2% of people were arrested, but we had warrants on those people. And for those of y'all who are in the mental health world who don't know what that means, like I didn't know what that means we want to arrest them. The people who we have warrants for, we're looking for them. So if you find them, you got to arrest them. Everybody else went somewhere else. And most of them, by the way, did not go to emergency rooms, because that's not all that good either. A lot of folks were able to get next day or same day psychiatric appointments at their local mental health authority. And that is often what people need, or housing supports, or just someone to say, hey, I think you'll be okay till morning, let's get you to the clinic tomorrow. And these are community paramedics, and they can show up the next day and help the person get to the clinic. So it's a pretty cool intervention. So I want to tell you about that. I do want to pause a minute, though, and go back up to this slide, because one of the things that's essential for these teams to work is 24/7 community crisis beds. And one of the things that's really hurting us as a state right now is the workforce crisis we're having. We are in the worst workforce crisis of my lifetime, and we've had a bad workforce situation to begin with, but now our community mental health system is losing people to Walmart that are hiring, Amazon service centers, everybody jacking their prices up. We weren't able to jack our wages up to be able to compete as quickly. So we have not just 40% vacancy rates in some programs, we actually have, like in some of our crisis teams, at some of our centers, over 90% vacancy rates. So those teams are being able to have to be staffed by other people. But the other crisis we have is in our state hospital system. Today, in our 2,400 bed state hospital system, 800 beds are offline. A third of our beds are offline and cannot be used because we don't have the staff to staff them. And it's not doctors and psychologists. Primarily, it's psych techs and nurses and the staff that have to do that. And I don't mean to be pointed about this, but I think it's important to keep in mind that those are the state-operated facilities. If you look at the partner-operated facilities, like the Harris County Psychiatric Center, the new Dunn Behavioral Health Center in Houston, none of those beds are offline. And it underscores to me real issues with asking a very inflexible state bureaucracy, even if it has the best people in the world. And I know some of y'all out there work in these institutions, and you're great people, and I admire the work you do, but you're in a system that doesn't really know how to operate hospitals, unfortunately. You as individuals do, but the system doesn't. It doesn't know how to flex up salaries to get more nurses in this region versus that region. And I would ask you to look at the other community hospitals in your communities and see how many of them have beds offline. I promise you it's not very many, because they'll go out of business. So we really need to take a hard look at that, and we're going to be pushing some of these hard questions this legislative session, because we cannot be waiting for the state of Texas to figure out how to be better at hiring people and filling positions. We have to figure out, we have unused hospital capacity in almost every community in Texas, that right now, if we had a state purchase program with those dollars, we could actually be filling beds. If we were partnering with those hospitals to operate lower acuity forensic units and and competency restoration units, which you can do in a private facility with the right supervision, we would be doing a different thing. So that's going to be a hard discussion, but it's one we need you all to be actively involved in, and certainly the commission will be looking at. So before I pause for questions, and I hope that I have spurred a few questions, or maybe even like rebuttals. I really like rebuttals better than questions. So if you have a rebuttal, that would be preferred. I want to talk a little bit about a new thing we're doing at the Institute, and I stole Yolanda Lewis, who's our new head of our Justice and Health Center, her tagline, which is access to care, access to justice. And really, we are focusing our efforts at the Institute and our hope to be even a better partner to you all than we have been, or a partner if we haven't been a partner up till now, through Yolanda's work. And I just want to tell you a little bit about that. The whole premise of what we're trying to do is to take the concept of being person-centered, meeting a person where they're at, but also making sure that there is an experience of not just justice as written in the law books, but procedural justice, which is the perception of fair treatment and equitable treatment within our justice system. So these are the standards we're trying to do, and we're not trying to pose these, we're really trying to find communities to partner with, because I think all of you are striving to do this as well. And a couple projects we're going to be happening, which I just, if you're interested, please see me and I'll link you to Yolanda. Part of it is not just having additional resources to respond, but changing the culture of response. And for those of you who were able to participate in our Engage and Excel conference, you got to hear Dr. Maya Collins share her tragic story of her family. I mean, this is a physician, someone who knew what her son needed, but when she called 911 in Philadelphia, which is the best funded mental health system on the planet. It's not about money, folks. It's about the response people have when they ask to have mental health people come out, they actually sent police, and they didn't send them until a lot later, until the situation had escalated and she lost her son that day. So, these are real avoidable tragedies, but it's not just the resources, it's changing the culture of how we respond. And Yolanda's team's working on that. We're going to be working on a person-centered triage approach to be able to help 911 and 988 call centers do a better job of screening and figuring out when do we send 911, when do we send emergency, when do we send mobile crisis teams. And then the other one, which I'm super excited about, is her care-focused adjudication work, which is really looking on those first 48 hours. What can we do to increase the safety and response of mental health within that once someone does come into the system? Because as those of you know who are in the justice system, and those of you who are partners, this is where we lose most people who we're going to lose to suicide and other types of bad things that can happen. So I just wanted to preview that. No specifics there because I really wanted to save time for questions, or rebuttals. So this is the time when we have questions and rebuttals. And there's microphones here and here. And I'm really good because I'm a therapist at staring at people until they talk. So, thank you, sir.
Good afternoon.
I think it's working. I think he's got to lean in.
Okay. Good afternoon. This is a wonderful presentation. My question would be, given that there is so much needed to be done, it looks like it's accumulated over years and whatnot, and salaries being one of the issues that will be discussed during the legislative session, what other things can you, for those of us who might be supportive or want to be supportive of the initiative to overcome the shortage, if you will, of the resources available, and what do you have a laundry list? I know you spoke to it, but the priority-wise, I know salary is one. What other types of things do you think that need to be discussed in the legislature, upcoming legislature? Because I try to keep an eye on what's going on or might be coming up in the 88th legislature. I'm a municipal judge, and I just saw a policy recommendation on how that might be a desire to expand Article 1622 of the Code of Criminal Procedure that no longer just mandates that people with Class B level misdemeanors and higher have a magistrate notified of a person who might be in crisis or have a mental illness or intellectual disability. I see that that's considered to be expanded to Class C misdemeanors, and at the Class C or the municipal level, we're the ones who see most of what goes on, and we have the least amount of resources. And if we get in behind, the legislative priority to expand salaries and whatnot, we want to know in what way that we can also cover the what's going on right now, and it might become statutory in the not too distant future.
Yeah, well, thank you for raising that, and thank you for being, I love that you're part of trying to figure this out. It's nice to meet you. So I'll share a couple thoughts. I'm sure other people may have some too if you want to share them during this discussion, but I guess one thing I want to say just parenthetically is this is affecting all of us, right? It's not just the mental health system. So it's our jails. Look at our juvenile justice system. The state juvenile justice system, the number of vacancies there. So, for a while, we're going to be choosing between a lot of bad choices. Fortunately, we know how to do that because that's what we've been doing, right? We've been choosing between bad choices our whole careers, those of you who are in this space. So I think we really have to think, even if the mental health system is under particular stress, fortunately, our local mental health authorities are stepping up and partnering and being there and figuring this out with you. So I think the most important thing is talk to your local mental health authority and ask them what they need. Have that discussion in your community. The Texas Council, I know, is going to be is working with HHSC, is looking at some things. The things we've suggested in there is let's look at some of the requirements for qualified mental health professionals. Do we really need only those degrees? Maybe there's some additional degrees. Can we also look at experience in lieu of degrees? Can we look at people who maybe have, law enforcement experience? There's a lot of experience that can cause you to be able to do a great job with an associate's degree or even a high school degree. So I think, waiving some of that. We have some requirements too around training and prescriptive therapies called the Texas resilience and recovery standards that were Beth, how many years has it been since those were developed? Yeah, okay, 20 years ago. And they were state-of-the-art 20 years ago, but the art has changed in the last 20 years. So we need to revisit those. I think they can be relaxed. And, I think, we also, beyond that, need to take an emergency This is an emergency. This is not business as usual. This is not the workforce issues we've had for a long time. So I'd like to see the governor look at some of the things they did after Hurricane Harvey, that they did after COVID, where they suspended state licensure requirements and said, we will take a license from any part of the country for a while. And, I'm a psychologist, but I'm not hurting for business. I mean, I don't think we're going to kill the psychology field if we allow the Oklahoma psychologist to help us for the next couple of years. I think we could do that for like a year and then see. And maybe that would also get our guilds and our fields to like think more proactively about how to have more of us homegrown, or maybe we steal some of those folks. Do they like practicing in Texas? The Texas Child Mental Health Care Consortium has worked with a lot of stakeholders to put out some recommendations that look at enhanced training, loan forgiveness. I mean, we do that stuff already. We could probably do some more. We could broaden it to more professions, looking at chemical dependency counselors, substance abuse counselors, as well as some of the more mental health pieces. But I also think we have to look at alternative providers. I think we really have to look at, every time we've done an assessment in the community, we find hundreds of inpatient beds in nonprofit, for-profit, private psychiatric facilities going unused because we don't have enough money to purchase those beds. And those facilities typically are operated at almost with full staffing. So I think we're gonna have to look at all the above solutions. But I think the most important thing is to have that conversation in your community and then bring those ideas to your legislature. And then we're gonna need to do a bunch of stuff. Oh, by the way, HHSC's, what's the item called? Exceptional item, where they're asking for additional salary increases across the board. We should do that. But that's not gonna be enough. So those are some ideas. If I missed some, please come up and share them at the mic. I followed you in. We walked in together.
Dr.
Yeah.
Keller,
Hey, good
how
to
are
see
you?
I'm well.
I have a couple of questions. I had to write them down.
Yeah,
I'm
please.
59, and I would forget by the
Yes.
time
Yeah.
I
Thank
walked over
you.
here.
Thank you. I'm glad someone else understands.
Does Meadows or the federal government track the rate or incidence of a person learning that they have severe mental illness when they find themselves in the criminal justice or juvenile justice systems and jails? That's one. Two is completely different and off the track.
Which I love.
Are there people advocating that Ph.D. psychologists in the state of Texas can be permitted to prescribe medicine?
I love that question as a PhD psychologist.
Exactly.
So let me take the first one first. So let me make sure I understood it. So the question is, is there data, is someone looking at the number of folks who are first detected their mental illness in a jail? Yeah. So one thing we know is it's too many. We're sure about that. And it's a lot. The estimates range. So some people will say, I think most of the estimates look at how many people in a jail or a prison have mental illness. And those estimates range because it's how do you define mental illness, right? I mean, if you define if they have an anxiety disorder, I promise you, if I go into jail today, my anxiety disorders could be a lot worse. Or, if you don't have an anxiety disorder and it's your first time in jail, you're gonna be pretty anxious. So it depends kind of how you define that. If we look at serious mental illness, we know it's above typically the baseline in the population, which baseline in the population of serious mental illness is it's in the single digits. It's more like in the 20% range typically to 30%. If you include substance use disorders and trauma, like everyone, but that's not your question. Your question is how many people find it for the first time? And so I don't think there's really good stats on that, but we do know that it's a time, the points of crisis are when a lot of people first detect, or when a lot of people first get connected to treatment. So I think of some of my family friends, they knew their young person was having issues, but they couldn't get them into care. And the one thing we know is a percentage of people with serious mental illness have agnosia. What is the agnosia? Yeah, that. They got that nausea thing. I'm not a real doctor, I'm a PhD, which is why I can't prescribe. We'll talk about that in a sec. They don't know they're ill. And that's one thing that goes with mental illness. Sometimes you don't know you're ill. By the way, that goes with other illnesses too. Like my doctor tells me I have high cholesterol, but I really don't think I do. So we argue about this quite a bit. But it makes it harder with a psychosis if you truly don't. And there are stats, actually I'll get you that stat, because there is a stat on what percentage of people with severe mental illness don't know that they're mentally ill. And it's, do you know? Is it that high? I don't think it's that high, Adrian. I think we're going to get the range. It's somewhere between 45 and 50% and 20. What? I don't think it's 45. Yeah, we'll get the stat and we'll see. And I'll either learn that's 45%, but it's a significant number of folks. The other thing, though, you got to look at is at what point in time are you looking? Because if it's like, if we're screening for anxiety at age 8, and we're having discussions with mom and dad who are struggling with this, because mom and dad knew something was happening. They knew it was psychosis, but they knew, my mom knew little Andy, like, wasn't exactly like the other kids. And so if we catch it earlier, I think we have a chance of being able to build that awareness. And I have seen young people too, once you get that first trial of med, the awareness changes. So I mean, I think there's a lot of different kind of pieces on that. But unfortunately, the world we live in now, we're not getting folks help typically until that is a very large percentage. So, and then psychologists, so here's the thing. If you look at the states where they allow psychologists to prescribe, they have standards, but they basically make you go to medical school. I mean, the standards you have to go through, it takes a couple years to go through the standards. And you learn all the stuff you don't learn in psychology school. And believe me, they didn't tell us anything. I mean, like, I don't even really know, like, I mean, they didn't tell us anything. So please, now I advise people, I'll advise primary care docs a lot of times on what I've seen in my clinical practice, but like, I don't know what the like interactions are with other medications. I don't know what the age things are, what the rule outs are. I mean, you got to go to medical school. So I personally think psychologists have a role, as we are, and that if you really want to prescribe, go to medical school or go become a nurse practitioner. I mean, like, there's a lot of other ways to do it. And I don't think there's a lot of value to be gained from arguing in the state of Texas to be able to have prescription privileges, because all the psychologists who want to do that are going to have to go to school for 2 years. So why not become nurse practitioners, have 2 degrees? Plus, nurses are way cooler than psychologists. So, yes, ma'am.
Pull this out.
Yeah, you is great. I could hear you.
I really appreciate the emphasis on there needs to be more access. One of the things that is very clear in the research on assisted outpatient treatment is what made the difference was access to services, not the force. But there's one voice missing here. I'm a person with lived experience in recovery of mental health issues. I run a peer-run, peer-governed, peer-operated service provider. We're missing the voice that we can have amazing and incredible lives, and that the conversation about diagnose and medicate does not equal an amazing life. And so if we're not, supposedly the system in Texas is a recovery-based system, I would say that is on paper. And we need to be having that conversation as well, because doing the same thing over and over again, expecting a different result, what have we been doing for years, and we get more and more people in jail? Yeah. More and more people. We keep saying add more beds, add more services, and we're not changing anything. We've got to have a cultural change. What we're seeing are traumatic stress responses that get labeled and medicated and never get treated. We're seeing so much. And, the statistic that 50% of people in the first episode psychosis get better. If you're outside the United States and Europe, they finish that conversation with, and they get better without any treatment in 3 to 6 months. First episode psychosis can go into automatic remission. With some support, 60%. There are things that we're not doing here because we're so dependent on pharmaceuticals. Yeah. And the forced treatment only makes sure we stay in the system. Yeah. I'm just saying, the school to prison pipeline, the school to psych hospital pipeline is based on a punitive system that punishes kids who are having a traumatic stress response. So if we're not including this in the conversation, we're just going to keep throwing money at this. We're going to keep building more beds. And one of the alternative providers that you mentioned, I think, should be peer support providers.
Yeah. Well, thank you for saying that. Thank you for what you just said. I 100%, well, I 99.9% agree. But I mean, the gist of it is I 100% agree. So first of all, let me take the last point that was just made. We got to look at our peer workforce, and we have to recruit more, because not only is there a lot of untapped skill there and looking at lived experience in lieu of educational and other professional experience, but also we should expand our Medicaid funded system to include family peer support, because families can also be super helpful to families. It's a different skill set, doesn't replace peer people who have their own lived experience of the illness, but it's another important thing, particularly for young people. The other point you made, I think the only point I'm not sure on, but I'm going to look at it, is I'm not sure the percentage is that high for spontaneous remission. I know it is significant, but I'm going to look at that. And if we could chat, I would like to know more about that. But if you look at early psychosis treatment, The most important, there's three things I think are most important about what's different about early psychosis treatment than typical psychosis treatment. One of them is that we use less medication. The point in early psychosis treatment is not to medicate to control, it's to have the person able to achieve their life goals with the minimal amount of medication, which in some cases is none. It also adds in education, supported education and supported employment supports, because that's the most important thing when you're 18. If 18-year-old Andy got a psychosis, the psychosis would have been hard, but it would have been even harder because 18-year-old Andy did not know how to take care of himself. I mean, 18-year-olds need to learn a bunch if they're going to be able to survive in the world, and supported education, supported employment support. And the last thing is family support. How do you help the family, whatever that means, the loved ones of that individual, on that individual's terms, not in a paternalistic way or in a family-driven way, but how do you help them be supports to the individual development and the life goals of that individual? So I think if we can do more early psychosis treatment and we have peer specialists as part of that, we're going to make better treatment. But you're right, there's not a single system in America that is as recovery oriented as it needs to be, and all of us need to be more recovery oriented. So thank you so much for saying that.
Dr. Keller, we have some questions that have come in online.
And I think I got one more minute, so I can do one.
Okay.
Yeah.
There are a lot of good questions online. So if I had to choose just one, I would say there was one that came in about personality disorders. There is a sentiment that personality disorders can be hard to treat. So how do we address that to decrease violence-related incidents?
Yeah, great question. So I think we really need to relook at personality disorders. You know, a lot of our understanding of personality disorders still harkens back to Freud, who's well, I don't know if he was a good guy or not. He tended to deny a lot of people's sexual abuse experiences and say they were fantasies. But we need to rethink those. And I think what we've done with borderline personality disorder is probably the most instructive. What we did was, rather than look at borderline personality disorder, which is a constellation of symptoms, I mean, you can discern someone who has a borderline personality disorder. But where the treatment really improved was with Marsha Linehan, who, by the way, has borderline personality disorder. And so she was able to, as a person with lived experience of borderline personality disorder, was able to help transform that treatment. They focused on what's getting in the way of living your life. Like, yeah, you got your own personality. My personality is a little weird. Having a weird personality is not an illness. Having an illness is having a lot of suicide attempts. It's calling your friends. It's going on shopping springes. It's self-harm. It's self-mutilation. So if you look at the discrete symptoms, then you also teach skills like mindfulness and being able to have self-driven controls of dysregulated emotion. We saw the treatment through things like DBT, dialectical behavioral therapy, tremendous improvements, well better than the traditional approaches that looked at a personality disorder. So my sense is, it's not that helpful to me to say someone has an antisocial personality disorder. It just means they went to jail a lot. I mean, if someone is psychopathic, don't hang out with them because they don't have a conscience. And that is a real thing that can happen. But even at the end of that road, that person had a conscience at one point. We just probably abused the hell out of him until it went away. I mean, if you look at the history of almost everybody who becomes a predatory criminal, there's a deep abuse history there. So it's not to excuse the behavior. It's not to say, well, okay, let's let the person out because they're going to hurt people. But it's to recognize that we need to do different things. So I am now stopping. This is awesome. Happy to chat with people at the break. Thank you for letting me hang out with y'all, and thank you for those questions.